We are going to talk about portal hypertension, starting from the definition itself. Then we'll study the causes of portal hypertension. Then we'll go into the clinical features, and then we'll look for the management. The management will do the investigation and the treatment of levels. So, starting with the definition, it is defined as when the hepatic venous pressure gradient is greater than 10 mmHg. Coming to the causes, causes can be classified further into extrahepatic causes, intrahepatic causes. In extrahepatic causes, just try to recall the anatomy. If there is a portal vein thrombosis, or there is a splenic vein thrombosis, or there is any trauma or tumor which is compressing the veins which are draining into the liver, all these are responsible for the extrahepatic causes. Coming to the intrahepatic causes, in intrahepatic causes, we have pre-sinusoidal causes, sinusoidal causes, and the post-sinusoidal causes. In the pre-sinusoidal, we have ascariasis, cystosomiasis, clonalges infection, sarcoidosis, graft versus host disease. Remember these things: ascariasis, clonalges, sarcoidosis, graft versus host disease. In the sinusoidal, let's see the easiest one. Remember hepatic cellular carcinoma, cirrhosis, Wilson's disease, alpha-1 antitrypsin deficiency. Coming to the post-sinusoidal causes, there we include the veno-occlusive disorders. Now coming to the post-hepatic causes, where we include Budd-Chiari syndrome, constructive pericarditis, right heart failure, or IVC obstruction. So these are the post-hepatic causes. So this was all about the causes of portal hypertension. Now coming to the clinical manifestation. In clinical manifestations, you will see ascites, splenomegaly, varices. Varices can be found in the esophagus, in the rectum, in the bare area of liver, in the umbilicus, presenting as caput medusa. In the esophagus, it will present as variceal bleeding. In the rectum, it will present as hemorrhoids. Coming to the investigation, investigation is the color Doppler. Now, how will you manage the patient? Management is like the emergency management, and one is the prophylactic management. If a patient presents you with bleeding, you will first insert 2 large bore cannulas. One is the IV fluids. Renal lactate is the fluid of choice. And to control the bleeding, we use the drug IV octreotide, or terlipressin can also be used, but most commonly octreotide is used. And if he is not bleeding, for prophylaxis, we use IV propanol. And coming to some surgical modalities available, which are the endoscopic band ligation and sclerotherapy. Like, if after the endoscopic band ligation the patient is still bleeding, then we'll do a second trial. And if the second trial also bleeds, then we go for a TIPS procedure. TIPS procedure stands for transjugular intrahepatic portosystemic stent. We create a stent between the hepatic vein and portal vein while going through the internal jugular vein. But there are various complications of the TIPS procedure. One is, as the liver is bypassed, there can be hepatic NCAF. The stents can get stenosed as well. And if the upper GI endoscopy is successful, we monitor the patient for 24 hours, and then we discharge by giving him oral propanol. And if you are in rural situation, you don't have any such procedures, then you can use some tubes are available, like the Minnesota tube, Lenton's tube, or the St. Stephen Blackmore tube. These can also compress and stop the bleeding. And apart from this, nowadays some selective and non-selective shunts are also available, which can be used. So this was all about total hypertension. Thank you for watching.